Pleasure again and honor to start our 5th day of our liver imaging series. And it is my pleasure to introduce Dr. Lee. So Dr. Jimmy Lee is an associate professor of radiology and associate program director and for the diagnostic radiology residency at University of Kentucky in Lexington. Jimmy, I have collaborated with him a lot and very, very nice again, guy. I mean, I'm saying again because yesterday also we have a very polite and decent man from Pittsburgh, Dr. Forlan. But today also is a very similar personality, very decent, very nice, very polite, down to earth. Dr. Lee, we're gonna learn from him today about LI-RADS ancillary feature. One of the very, very nice things about LI-RADS is this ancillary features. I mean, when you read through the ancillary features and you see the group efforts of just sorting them out, you would really love LI-RADS, even though it's optional, but it gives you just the fund of knowledge and the confidence of the characteristics of benign and malignant observations in cirrhotic liver. So, we'll start now with Dr. Lee. Dr. Lee.
Okay, thank you, Dr. Elsayes, for that kind introduction. And just if you were listening earlier on, just thank you again so much for organizing this great lecture series in such a short time. Thank you especially for inviting me to speak. I'm very humbled to be part of this webinar series. I'd also like to take some time to acknowledge one of my mentors, Dr. Cynthia Santillan, as well as Dr. Antane, who provided many of these following slides. And it's really the entire LI-RADS community that have contributed to these slides. So if you tuned into the last few courses, you've been introduced to ancillary features and their use in LI-RADS diagnostic algorithm. As you can see from this page, out of the core document for CT MRI LI-RADS, applying ancillary features is step 2 in a 4-step process of arriving at a final LI-RADS category for hepatic observations. The core document, along with other LI-RADS documents, are available for free download at the website indicated here. So why are these imaging features referred to as ancillary features? Many of these features are identified on widely available imaging modalities and furthermore recognized by many radiologists to be associated with hepatocellular carcinoma. So why do we refer to them as ancillary? The reason are manyfold and touched on by the lecture provided by Dr. Chernek while discussing major features in isolation. Remember, she showed that even some of the major features in isolation lack the specificity to diagnose HCC on their own. This is definitely the case when it comes to many ancillary features. Furthermore, the prevalence of many of these ancillary features are low, and therefore it doesn't warrant to increase the complexity of LI-RADS. Evidence continues to grow regarding ancillary features, but at the release of the 2018 version, many of these still lack sufficient data to move them into the major feature category. So how do we apply ancillary features? The answer is simple: to adjust the category that you arrived at after you completed step 1 of the diagnostic algorithm. For example, if you landed here on LI-RADS 3 box after applying all your major features, you would then apply ancillary features you observed to adjust the category up to LI-RADS 4 or down to LI-RADS 2, dependent upon which features you found. Furthermore, ancillary features are optional and can be used at the radiologist's discretion to improve detection, increase their confidence in making a final LI-RADS category, or as I just said, to adjust the LI-RADS category itself. When you use ancillary features to adjust categories, you must follow a few simple guidelines. Okay, so when you do use ancillary features to adjust the categories, you must follow a few simple guidelines. First of all, no matter how many ancillary features you observe, you can only change the category by one. So you can go from an LR1 to an LR2, an LR2 to an LR3, an LR3 to an LR4, or you can move from a 5 to a 4 to a 3, etc., based on whether you see ancillary features that suggest malignancy or ancillary features that suggest benignity. Notice, however, that you cannot use ancillary features to upgrade a LI-RADS 4 observation into a LI-RADS 5 observation. Again, this is to preserve that near 100% specificity that LI-RADS 5 connotes. So let me just say that one more time. You cannot use ancillary features to upgrade an observation to LI-RADS 5 if the major features did not categorize it as such. Furthermore, the lack of these features should not be used to adjust categories. For instance, one of the ancillary features that suggests malignancy in general is restricted diffusion. If an observation does not have restricted diffusion, it should not be downgraded simply because of its absence. What if you have conflicting ancillary features? The answer is simple here. You just don't adjust the category. So once again, ancillary features are imaging features that are not major features that have been previously described in other lectures in this series. They are subdivided into benign and malignant, as you can see on this slide. Features that are associated with benignity are listed on the left, and ancillary features that are associated with malignancy are listed on the columns to your right. Furthermore, you can see highlighted here are features that are MRI specific, which segues nicely into the suggested reading for this topic, which was published in Radiographics by many of the esteemed colleagues giving lectures this 2 weeks. Please also note the opportunity for essay CME, self-assessment CME, after reading this article. So let's dive into benign ancillary features. First off, size stability greater than or equal to 2 years or size reduction are rather self-explanatory. If an observation is stable or getting smaller, it's very unlikely to be malignant. Tumor volume doubling time varies. Tumor volume doubling time varies greatly for HCC depending on the level of dedifferentiation, reportedly ranging from 12 days to just over 2 years. So if an observation is stable in size at or beyond 2 years, it is likely to be not benign. Observations whose enhancement pattern parallels blood pool on all phases of imaging is also a benign imaging feature. Here you can see a classic giant hemangioma that enhances discontinuously in a fashion that follows blood pool. Other vascular abnormalities such as fistula, pseudoaneurysm may follow blood pool as well. Undistorted vessels or vessels passing through an observation without displacement or deformity is another feature that suggests benignity. Here you can see an undistorted vessel indicated by the arrow passing through a transient perfusional alteration in segment 4 of the liver. Continuing on, you can see iron in a mass or observation more than the background liver, which are commonly referred to as siderotic nodules and frequently occur in the setting of cirrhosis. Pathologically, these are typically low-grade dysplastic nodules and therefore considered a benign imaging feature. Marked T2 hyperintensity is when the observation has similar T2 intensity to that of bile ducts and other CSF fluid structures such as the stomach and the CSF seen around the spinal cord on this example. Cysts Hemangiomas, biliary structures are some of the entities that have this benign imaging feature. The final ancillary feature is hepatobiliary phase isointensity, which refers to the signal intensity equal to or near equal to background hepatic parenchyma when using hepatobiliary contrast agents. The reason that this is considered a benign imaging feature is that most HCCs have reduced or non-existent expression of the organic anion transport protein and are typically hypointense during hepatobiliary phase. Isointensity suggests hepatocytes with functional OP seen in regenerative nodules, low-grade dysplastic nodules, or arterial portal venous shunts, as you can see in this imaging example. So moving on to ancillary features that favor malignancy, you may have noticed that they were separated into two boxes. The top box is for features that favor malignancy in general, whereas the bottom box are features that are more specific or particular to hepatocellular carcinoma. So let's look at each of these features in detail. Ultrasound visibility as a discrete nodule is pretty self-explanatory. So ultrasound visibility as a discrete nodule is pretty self-explanatory. And the rationale is that the most common benign masses or findings in the cirrhotic liver, such as regenerative nodules or low-grade dysplastic nodules, and all other benign vascular pseudo-lesions are invisible on ultrasound. So if you see something on ultrasound and confirm it on CT or MRI, it is more likely to be an HCC, as in this example here, which turned out to be a pathologically proven hepatocellular carcinoma. Ultrasound effectively increases your pretest probability for the diagnosis of HCC at diagnostic CT and MRI if you find that exact same observation that you identified on ultrasound. So subthreshold growth refers to unequivocal growth of a mass, but less than that required for the major feature threshold growth. Remember, as described by previous lectures, LI-RADS version 2018, threshold growth is defined as a 50% or greater size increase in 6 months or less. So subthreshold growth may be a size increase of less than 50% in a time interval of less than 6 months, or any size increase in a time interval of 6 months or more, or a new observation of any size. So again, this goes back to the wide range of tumor doubling time in hepatocellular carcinoma. The median tumor doubling time has been reported to be about 6 months in an untreated hepatocellular carcinoma. And if it gets local regional treatment, the doubling time has been reported to be a little bit shorter, about 3 months. But as with all neoplastic processes, aggressive and poorly differentiated cancers tend to grow faster than well-differentiated ones. Restricted diffusion is a feature that favors malignancy in general. It refers to hyperintensity on DWI, not attributable solely to T2 weighted imaging shine through. Restricted diffusion is frequent in all malignant neoplasms and is not considered specific for hepatocellular carcinoma. ADC maps often can help to characterize this feature, but are not required. Remember also to use DWI sequences to increase your ability to detect those focal liver lesions. Mild to moderate T2 hyperintensity is also a feature favoring malignancy in general. It refers to intensity on T2 weighted imaging mildly or moderately higher than the liver, similar to or less than a non-iron overloaded spleen. So if you're comparing to a normal spleen, it's similar to that as an internal reference. Signal intensity greater than this spleen may indicate that you're actually dealing with a hemangioma or cyst. and should not be characterized as mild to moderate T2 hyperintensity. Here's a great example of observation that shows that classic mild to moderate T2 hyperintensity. Now, corona enhancement is a feature that favors malignancy and refers to this peri-observational enhancement that you see in the late arterial phase or the early portal venous phase. And so I'll just repeat those phases. It's seen in the late arterial phase or the portal venous phase, attributable to venous drainage from the tumor. Hepatocellular carcinomas do not drain into the normal hepatic veins. These veins are destroyed as the tumor develops. Instead, HCCs drain via sinusoids and portal venules into the surrounding parenchyma. This produces and constitutes what they call the venous drainage area or corona. Some metastatic lesions, although, may have this peritumoral or peri-observational neovascularity, and thus it's not a specific finding for hepatocellular carcinoma. I lumped these two together, the fat sparing and iron sparing in a solid mass. So when the background liver is fatty or iron laden, observations that are spared of this diffuse change is a feature favoring malignancy. In this example, there is diffuse hepatic steatosis, and the focal observation spares the steatotic change, as you can see in this opposed phased image on the lower half of the screen. When there is diffuse abnormality of the liver, it provides an additional opportunity to detect those focal hepatic observations. So use those to your advantage. Lastly, in this category, transitional phase and hepatobiliary phase hypointensity is a feature that favors malignancy in general. It refers to the intensity in the transitional or hepatobiliary phase that is unequivocally less than background liver. This goes back to the discussion that we previously had regarding the expression of OP. And because other malignancies can also produce this similar appearance, it is not specific to hepatocellular carcinoma. So now we're going to move into ancillary features favoring malignancy that also are more specific to hepatocellular carcinoma. A non-enhancing capsule is a feature favoring HCC. It refers to the appearance not detected as an enhancing rim, as discussed by Dr. Fowler the other day. This feature is thought to represent an HCC tumor capsule, and tumor capsules are very common in HCC, but rare in other malignancies in the cirrhotic liver. Therefore, this non-enhancing appearance is considered very specific for HCC in particular. Unfortunately, it's not present very often and thus put into the ancillary feature category. The nodule and mosaic architecture share some of the imaging findings and are both features that are favoring of hepatocellular carcinoma in particular. It refers to the presence of a smaller inner nodule within a larger outer nodule. It is thought to reflect the development of a less differentiated inner nodule. Being less differentiated, the cells then have a survival advantage over the other cells. So over time, the inner nodule expands and replaces the entire outer nodule. Although this is pathognomonic for HCC, this growth pattern is difficult for us to confidently and reliably characterize radiologically. So we consider it, again, an ancillary feature. Blood products in a mass refer to the intralesional or perilesional hemorrhage in the absence of biopsy, trauma, or intervention. HCC vascular tumors that may spontaneously bleed. Blood products are typically heterogeneous in appearance on both T2 and T1 images, depending on the chronicity of the hemorrhage. you can see areas of both T2 shortening and prolongation in this heterogeneous observation. So fat in a mass more than the adjacent liver refers to excess fat within the actual mass or observation. And it can be at the entire observation, or it could just be part of the observation. And it's relative to the background liver. Intracellular fat and HCC can be diagnosed at MRI as a drop in signal intensity of the mass on opposed phase gradient echo images when you compare them to the in phase. Here is the in and out of phase. For those of you with kind of eagle eyes, you probably observed this exophytic observation hanging off the left lobe of the liver, right here. And since pure cholangiocarcinoma do not have fat in them, this feature is more specific for HCC in the cirrhotic liver. Okay, well, let's do a few cases just to apply some of the information that I just spoke about. And so here is a case, and I'll give everybody just a few seconds to look at this before we go on to categorizing it. But if you were using the LI-RADS CT MRI diagnostic algorithm, MRI in this case, what category would you end up with? So we did our initial check marks, and now we ended up at the diagnostic table. So first, we want to see, does the observation demonstrate arterial phase hyperenhancement? And the answer is no. So we know we are in this category of observations. We then estimate that this is about 23 millimeters. So now we further are in this second column. Moving on, we count the additional features. We don't see capsule, non-peripheral washout, or threshold growth. So moving on, we ended up with LI-RADS. Okay, let me just go back here. So we ended up with a LI-RADS 3 based on major features using the diagnostic table. So let's apply those ancillary features now to see where and if that can help in our diagnosis and our final category. So we see that there's fat in the mass and adjacent, more than in the adjacent liver. You can see on opposed phase and in phase imaging that this clearly has intracellular lipid. There's mild to moderate T2 hyperintensity. You get a little bit of spleen here, but it's probably mild T2 hyperintensity. And then we show that there's restricted diffusion within it, and we know that we're dealing with a higher B value just looking at the central canal here at the same level. So if we apply these ancillary features, we can actually upgrade this observation to a LI-RADS 4, which means a lot for the patient. So it's very important to use these ancillary features, although in the current version of LI-RADS, this is optional for the user. But no matter how many ancillary features that we saw, we counted 3 ancillary features. We might have been able to count more. We cannot upgrade by more than 1. And furthermore, we can't go from a LI-RADS 4 to a LI-RADS 5. Let's look at one more example here. And again, I'll give you about 10 to 15 seconds to look at this observation. Okay, so it did not meet any of the imaging criteria in our initial check, so we ended up again at the CT MRI diagnostic table. We show that there's non-REM arterial phase hyperenhancement, either the entire lesion or in part. And then we see that the observation is greater than 2 centimeters. This one was about 4 or 5 centimeters. And we see that we have washout and a enhancing capsule. So we end up here with 2 of the additional major features, and we arrive at a LI-RADS 5. So now we apply those ancillary features again. So here we have a nice example of blood products within the observation. We see that mild to moderate T2 hyperintensity. Again, use that spleen, that normal spleen, for an internal reference. And there is a mosaic architecture within this observation. So those are all features that not only a few of them are suggesting HCC in particular, but they all favor malignancy. But it really didn't matter in this case, right? Because we had a LI-RADS 5 category already. So ancillary features, like Dr. Elsayes had said in the beginning, are really important because they're really, I think, and I think a lot of other radiologists believe as well, allow you as the radiologist to add more value, not only to research, but to validation of other features. So I implore you, and we implore you, to use these ancillary features, apply them, and use them as you feel fit. So with that, I just will end my presentation. Here again is the core document, step 2. All of the ancillary features here are illustrated, and lastly, just the recommended reading that I would recommend for further diving into these ancillary features. So thank you for the time and the opportunity to speak.
So thank you very much, Dr. Lee, for this informative lecture. Again, I actually have a personal preference for ancillary features and I teach it a lot to my residents because I really feel that they are important, they're evidence-based, they have support from the literature when you talk about the signal intensity, for example, in the T2, and the signal intensity in phase, out of phase, the presence of fat, the DWI. All of these are very helpful features that may not just help with LI-RADS category, but also help in the thought process of understanding how we characterize focal observations in cirrhotic liver. And it's not only your LI-RADS, but it help you maybe process similar information with other pathologists and other organ systems. So we appreciate that informative lecture. And